Neurology Unit Part 3, Problems of the CNS, the Spinal Cord. Multiple sclerosis is an autoimmune disorder that destroys the myelin sheath of the nerves in the brain and spinal cord. It is chronic and has different types. It is more common in Northern European ancestry, and they are at higher risk due to the colder climates. The 4 types of multiple sclerosis, the first is relapsing remitting. This is the most common. Symptoms develop and resolve in a few weeks to a few months, and then go back to baseline. Primary progressive, there's a steady and gradual deterioration without remission. This type typically develops later in life between the ages of 40 and 60. Secondary progressive MS begins with relapse remitting, but later becomes a steady progression of the illness. 50% of these cases develop within 10 years of the diagnosis. And lastly, there's progressive relapsing. This is frequent relapses with partial recovery, but they do not return to baseline. Assessment findings with MS include clumsy motor movements, blurred vision, tremors, gait changes, fatigue, and muscle spasticity. Priority problems with interventions. We want to make sure we're looking at the potential for infection due to the impaired immunity based on the drugs they are receiving. We want to help with improving mobility, managing the decreased visual acuity, and then making sure that the client has connections to healthcare resources as more services may be needed as the disease progresses. Drug therapy with MS includes anti-inflammatories such as corticosteroids, which is what makes these clients vulnerable to those secondary infections. Also, immunomodulators help with homeostasis of the immune system. Amyotrophic lateral sclerosis, otherwise known as ALS or Lou Gehrig's disease, is a progressive muscle weakness and wasting, leading to paralysis of the respiratory muscles. ALS is always fatal due to respiratory failure. It is important with patient teaching that the patient is aware of the severity of the diagnosis and prepares accordingly, such as encouraging advanced directives and living wills. There's a higher incidence of ALS in males. Ages 40 to 60 is the most common. Signs and symptoms include fatigue, muscle weakness, atrophy, twitching of the face and tongue, dysphagia, stiff or a clumsy gait, and abnormal reflexes. Drug therapy can include one approved drug, Riluzole, which is known to slow the progression of the disease, but does not cure or stop the progression. Palliative care is necessary to manage symptoms, and psychosocial support is also needed. There are several different ways that spinal cord injuries can happen. Hyperflexion is a forward motion. An example of this would be an acceleration of the head forward, such as in a head-on collision, or falling backwards onto the buttocks, which causes that hyperflexion. Hyperextension is a backwards extension. Example would be rear-ended in a motor vehicle crash, or a fall where you hit the chin and then the head hyperextends back, damaging the spinal column. Axial loading or vertical compression. An example of this is diving headfirst into a swimming pool. This will cause the bones to shatter and enter into the spinal canal, damaging the cord. Excessive head rotation is turning the head beyond its range, causing damage to the spinal column at the cervical area. And then a penetration injury would be an example of a gunshot or knife wound at the spinal cord. This slide shows axial loading or vertical compression injury of the cervical spine and the lumbar spine. Spinal cord injury initial assessment starts with airway, breathing pattern, and circulation, assessing the respiratory muscles. Indications of intra-abdominal hemorrhage or hemorrhage and bleeding around the fracture sites is also important. Monitor for abdominal distension and or pain. You can use the Glasgow Coma Scale to assess the level of consciousness. The level of injury is divided into different terms. Tetraplegia and quadriplegia involve all 4 extremities. Quadriparesis is weakness in all 4 extremities. Paraplegia is the lower extremities being paralyzed. Paraparesis is weakness in the lower extremities. Spinal cord injury management involves maintaining an airway and cardiovascular system, the ABCs. There's a high risk of respiratory compromise if the cervical spine nerves are involved that control the diaphragm. Management also involves log rolling the patient, good skin care, emotional support, adequate nutrition, and then reducing aggravated factors that may cause spasticity. Patient will also need bowel and bladder training, and the patient and family will need education and support to cope with the detailed care at home. Immobilization is sometimes done through a surgical fixation or a halo fixator traction or a surgical repair. Drug therapy can involve an intrathecal baclofen implantable pump into the cerebrospinal fluid. This is a way to deliver medication to decrease the spasticity. Also can be used are Celebrex and muscle relaxers. Surgical management is typically done within 24 hours of the injury to decrease any secondary complications. And then additional community resources for the patient and family include the National Spinal Cord Injury Association. Spinal shock can occur when there's no reflex activity below the level of injury. The muscles are without sensation or movement and are flaccid. Neurogenic shock usually occurs when the injury is at T6 or higher, and there's a loss of autonomic nervous system function. This can result in hypotension, abnormal thermoregulation, decreased pulse, decreased cardiac output, venous pooling or edema, and no perspiration on paralyzed portion of the body. Injuries greater than C3 according to Kaplan or C4 according to your med-surg textbook result in paralysis of respiratory muscles and all four extremities. The higher the injury, the greater the loss of function. This slide looks at the levels of the spinal nerves to determine what kind of impact an injury will have depending on at what level the injury occurred. Priority problems for long-term management of spinal cord injuries include difficulty breathing, impaired physical mobility, and the safety associated with that, spastic or flaccid bladder and bowel, and the impaired adjustment. Autonomic dysreflexia or hyperreflexia is an exaggerated autonomic response to stimuli that are harmless to normal people, but in patients with cord lesions above T6, they can become potential for being life-threatening. This causes an increase in activity or an overreaction of the sympathetic portion of the autonomic nervous system. This can be caused by minor stimuli, such as restrictive clothing, a full bladder, pressure areas, or fecal impaction. Those stimuli then cause vasodilation above the level of the injury, resulting in increased blood pressure, which is rapid and severe, and if untreated can cause stroke, seizures, and death, a flushed face, a headache, distended neck veins, increased heart rate, and increased sweating. It also causes vasoconstriction below the level of injury, so the patient could appear pale, cool, or have no sweating below the level of injury. This is an emergency. As a nurse, you want to sit the patient in high Fowlers, decrease the stimuli, loosen the clothing, reposition, and assess bowel and bladder needs. Call the provider, administer a calcium channel blocker, such as Procardia or nitrate, to decrease the blood pressure. There are three types of spinal cord tumors. Primary, originated in the spinal cord. Intramedullary are in the cord, and extramedullary are outside the cord within the spinal dura. Most of the times, these tumors are metastasized or secondary to another cancer site. The assessment findings depends on the location. Priority problems with the interventions include surgical management, emergency surgery to remove the tumor, or non-surgical management, radiation and chemotherapy to shrink the tumor. Symptoms will be pain in the back, headache, loss of sensation, decreased mobility, decreased sensation, or loss of bladder and bowel function. 80% of adults complain of back pain at some point in their life. 52% of nurses report chronic back pain. 12% of nurses leave the profession related to back pain. Back problems are typically diagnosed using MRI or CT scanning. The disc or cushion between vertebrae weakens and flattens with age. Wear and tear can cause protrusion or a bulging disc or a ruptured disc. Herniated nucleus pulposus or herniated disc is the rubbery disc between the spinal bones pushing through a crack. This can be asymptomatic or symptomatic. Symptoms: it can irritate nerves resulting in pain, numbness, or weakness in the upper or lower extremities. Sciatica nerve affected. Degenerative discs is when the discs between the vertebrae lose their cushioning due to spondylosis, which is age-related wear and tear on the spinal discs, degeneration of the spinal column, or osteoarthritis of the spine. When the discs rub or crush together, spurs can develop. Preventative measures are important to avoid chronic low back pain. Prevention includes good posture, exercise, good body mechanics, and stretching. Ergonomics are about efficiency in the working environment. Equipment uses include making sure the height of the bed is correct when working, using lifts, using transfer belts, and encourage patients to help or get more staff so that you can avoid injuries as a nurse. Non-surgical management of back pain includes positioning. Williams position is suggested, which is the semi-fallers with knees elevated. Drug therapy can include NSAIDs, opioids, and antidepressants, which are adjuncts for pain. Heat therapy, as heat may help heal the nerves. Physical therapy, weight control, complementary and alternative therapies, as well as using a TENS unit that stimulates the nerves in the area and helps block the pain sensation. Surgical management of back pain can include minimally invasive procedures such as percutaneous lumbar discectomy, which is an endoscope removing the damaged disc material from the herniated disc, thermodiscectomy, which uses heat to shrink before you remove it, and laser-assisted laparoscopic lumbar discectomy, which uses laser and scope through the umbilicus. This is used to treat a bulging disc that doesn't involve the vertebral canal. Conventional or open surgical procedures include a discectomy, which is removal of the disc, a laminectomy, which makes the hole bigger by removing part of the vertebrae, removal of the lamina, and enlarges the spinal canal to relieve pressure on the cord or nerves, or a spinal fusion, where vertebrae are fused together with screws joining two or more vertebrae and can be done at any area on the spine. This can restore the disc height. Postoperative care for back surgery includes assessing for complications. There can be permanent nerve damage. Post-op checks should include neuro checks and vital signs, watching for fluid volume deficit, urinary retention related to anesthesia, pain management, wound care, and assessing around the dressing for any leakage of cerebrospinal fluid. Should also be assessing for bleeding or clots. A fat embolism is the most common in spinal fusions. Nerve injury, again, leakage of cerebrospinal fluid, and any signs or symptoms of infection. Cervical neck pain is most often caused from herniated disc or a bone spur. Conservative treatment would be exercise or using a soft collar that's worn at night, especially to stabilize the neck. This should only be worn for 10 days or less, as it can decrease range of motion and muscle strength. Surgical management includes an anterior cervical discectomy or fusion. Nursing indications: maintain airway related to complications related to swelling, breathing, swallowing, and risk for aspiration.